here are my disclosures for this conference. And basically, I'm not going to go over again, and you will see throughout this meeting all the different devices and modalities that have been developed over the few years on excluding the left atrial appendage, both from the endocardial as well as from the epicardial approach. The only one that I know that 100% guarantees exclusion is when the surgeons excise, not when they close, but when they excise the left atrial appendage. Other than that, I think it's very dependent on how we approach that procedure. We do need, and I'm not going to repeat all the beautiful presentation by Professor Ho on the different morphology, osteal shapes of the left atrial appendage. Not only that, but the curvature and the number of lobes. But how do we interpret that? I mean, we use this classification that we saw so many times as chicken wing, windsock, and I'll show you. This is based mostly on the images that were obtained from a CT, but the way that is being used is by angiographers using a fixed projection, whether we know beforehand or not that the appendage is facing anterior or posterior. We don't, and we make this classification. And here I'm going to show you, this is a one CT with 3D reconstruction that shows that I can show you any shape you want based on the same left atrial appendage. It all depends where I'm looking at from. I can show you that this looks like a chicken wing, as a windsock, a cauliflower, or a cactus. It all depends how I turn. So angiography is very misleading. It's only a 2D representation. This extends on how we do the measurements. Again, whether you use CT, whether you use echo, most of the measurements are done based on 2D. And I think if you want to do that, you have to use those tools appropriately. For example, if we are using CT, we need to use curve MPR, where one can trace and put this image of the left atrial appendage in one single plane, trace the center line, and one can do measurements perpendicular to the central line. Of course, CT may even be more accurate in detecting clots than echocardiography. But you saw the talk from Nina Wunderlich on all the qualities of the measurements from using 3D TE. And on the right side of the panel, you can see, again, one patient that had a post-closure using the Lariat device. And you can see the whole of the opening that was remnant from the closure that confirmed by contrast echocardiography that there is flow and the presence of a clot. So imaging becomes absolutely fundamental. But let's go to the basics. What is the function of imaging? What is the function of imaging? I think the rules are very simple. We need to obtain and display data from that imaging that makes things visible, number one, that exploits the natural relationships of the couple and functions and control, that makes intelligent use of each technology constraints, and accurately and reliably identifies and characterizes the targets that we're going to use from this imaging with one goal. What is the goal of that imaging? Is basically to guide the user effortlessly to the right action on the right control at the right time. That is, to me, what imaging is all about. So this is how we use imaging today. We basically obtain the data, and we display that data as a Chinese shadows. That's basically what we are doing. And based on these Chinese shadows, now we are planning our intervention. Now we take the patient to the Cath lab, we try to do the intervention, and we obviously need to improvise on that intervention. And that improvisation is basically based on educated guess from the images that we obtain. And I think this is a very archaic way of really looking at imaging and how to do these procedures. So let me ask the question. Can we pose the first question? is, do the current imaging modalities provide all the necessary information and guidance to accomplish our therapeutic goals? This is not the question, but if you can go back to my questions, there we go. Is basically, is it currently yes, is sometimes, or currently never? Well, I'll tell you the answer before you can even reply, that I think it's very hard to say, but it's obvious that at this point, we really need to move towards a more intelligent imaging. And what do I mean by that? Let me show you what we do. Using the pre-acquired CT on those patients, we plan those interventions very carefully. And here, and you saw from Dr. Wunderlich's talk how important is, for example, the transeptal access point. There is no reason to guess. We can play on these images and find the more coaxial point, not only to the orifice of the appendage, but to the entire body of the main body of the entry of the left atrial appendage. And based on that, we can then bring that into the Cath lab, overlay those images using fusion imaging from the pre-acquired CT onto the fluoroscopy, and that will guide us very accurately without having to guess whether it's a chicken wing or it's a windsock. We know exactly where we're going, and having analyzed those images from the 3D point of view. Now, we have something that is a problem, and I'll go over that, is that these images have been pre-acquired, but now we have the capability of using overlay real-time 3D TE with fluoroscopy. And we started a few years ago using, as you can see in here, on the left-hand panel, what we started was just putting markers on the 2D images acquired from the 3D TE. But now, on the right-hand panel, you can see that we can overlay the real 3D image on the fluoroscopy. Not only that, but we can also superimpose 3D color flow Doppler that can be overlaid onto the fluoroscopy and tell us the real thing as we see it on fluoroscopy, really synchronized. So when we see the whole image together, which is the triple fusion imaging that we are using in our lab, you have basically the overlay of the pre-acquired 3D TE CT with also the overlay 3D TE that really can guide you to do the interventions adequately. So I have shown you that fancy, I call it fancy, but what are the real challenges? This is what we are today, and this is in the forefront of imaging in interventions. But where are we challenging today? Well, first of all, is the reliability of this image. What is the reliability of those image modalities that I have shown you? I think the reliability relies primarily on the quality of the imaging source, whether it's CT, whether it's echo, whether it's MRI. Also, the quality of the post-processing, how those images are post-processed. And, of course, the quality of the interpretation of that images. So if we can, the goal would be to bring that to an equalizing point on qualifications and experience that will give you the best outcome. Accuracy of the fusion technology, how accurate is that? Well, if one looks at the CT, the accuracy also depends on the time lag from the time that you acquire the CT to the time that you overlay it. And any time lag is going to be a discrepancy. Needless to say, the positions of the patient's arm, whether the patient had an effusion or not, all this is going to change definitely that overlay position on the fluoroscopy. But what about CT and fluoro and echo? That's real time. Now we can say that is more reliable. Well, let me beg to disagree to that, because it depends on how these images is registered. The registration is constantly, it's an ongoing registration with the probe of the echo, that it depends on whether the fluoroscopy sees those dots of the transducer in a coaxial way to the X-ray or if it's a little tilted. So the box that is generated by this computer can be also misleading. So all these needs to be improved, and I'm showing you that there are other problems. What are the other problems? Motion compensation. What is motion compensation? When we overlay fluoroscopy and CT, you can see here very clearly that there is a compensation from the cardiac motion. And each cardiac cycle, you can see one single phase as opposed to the fluoroscopy that is real time, and you can see how much that varies. But also the patient is breathing, and you can see the variation between breath and breath on the cardiac motion. So all these are difficulties that we are facing today with this technology. The next one is the tissue deformation that occurs during the procedure. And you can see that the markers that we put are very accurate, both on the CT on the right-hand side or the fluoroscopy on the echo on the left-hand side. But when you start pushing with the needle, you're moving those tissues, and no longer those markers correlate. So it's only when you leave, you're only tagging one point in the space at one part of the cardiac cycle. And that is a difficulty that needs to be overcome from the computer programming point of view. Where we should be moving at is the ability to use patient-specific anatomy to do virtual reality testing and simulation. And there is no reason why that cannot be done. Today, rapid prototyping of printing of 3D imaging is very readily available, costly, but readily available. And I think that will enhance our understanding of the anatomy before we do these procedures. But we need to do something more. We don't know what's going to be the deformation of the device, the deformation of the tissues. And this is something that we start already working with Professor Folk from well, no longer from Zurich, I think he's from Berlin now, that is developing mathematical modeling with our group that can predict what deformation of the device will take once you place it on that specific location. We start working with that with the TAVRs. So in summary, I think that imaging future is not only obtaining the image and post-processing, but we need to do something more. We need to bring that imaging post-processing into a mathematical modeling that we can then bring into an intelligent simulator that can repeat the procedure X number of times before it gets performed. And then based on the results of this simulation, if you have 80% of the time that you succeeded in closing that appendage successfully, 100%, that is information that can be brought, extract, and brought into a computer that can guide in a different ways the implementation of those procedures. Finally, I think the display of the images, in spite of all this fancy 3D imaging reconstruction that we do, we still display the imaging in screens, which are basically 2D, two-dimensional. And I think we need to move towards the holographic display where one can really display the image in 3D and actually interrogate that image in 3D and interact. And that, I think, will tremendously facilitate the interaction between the imaging obtained and the operator for the interventions. So, summarizing, I think the advance in 3D acquisition technologies has made a big revolution in understanding the anatomy. The fusion imaging technology, I want to make sure that you understand that it doesn't bring any new imaging information. It just enhances the collective point of these multiple imagings into one single outlet of information to the operator. And finally, I think, as we said, the imaging has to move towards what I call intelligent imaging and predicting how the procedures need to be performed in a safe manner. And I thank you very much for your attention.